surgeries in 1 year than the other 3 combined. If somebody's going to stick a knife in my eye, I want them to be steady. So he does 670 cataract surgeries a year on Wednesday every week. So he's got it down, and I was pretty impressed with the overall process. Also, I was sitting in the Mayo Clinic who claims to do things very well, and I was watching a 19-person line up to get into the neurology department, and I'm thinking somebody isn't applying Lean or Lean Six Sigma here, even though they claim to. So I started getting involved with this about 3 years ago, and one of the people I'm working with is a person by the name of Judy Ryan, who was retired CEO of the Good Samaritan senior care facility in the United States. It's the largest senior care, nonprofit senior care in the United States. They have 213 facilities and 19,000 seniors they look at. And you'll see some slides up here from a woman that I've been working with, and she has a book called Medicare, which is pretty good. There's another book that I thought was pretty good called Lean Six Sigma in Healthcare. Both of those books are on the table over there if you want to leaf through them. So with that in mind, I also want to speak to this. I've always had trouble explaining this from the perspective. This is sort of my secret weapon for dealing with complexity. And this comes out of cybernetic modeling, which was originally invented by Norman Wiener in the 50s or 60s, and then Stafford Beer wrote a book, Brain of the Firm, Heart of the Organization, and Diagnosing the System for Organization. And I'll explain this on and off as I put up slides, but basically it's a way for distributing decision making throughout the organization and allows an organization to be much more adaptable. These things at the top come from a standard process model for healthcare, which I'll also speak to, and then I'll speak to Michael Porter's integrated practice unit as we go along here. Challenging communities everywhere is developing, funding, and implementing elderly health care. One of the things that struck me in the middle of the night last night is I'm worried about patient flow to value, but in a hospital setting where a person goes from station to station, but with an elder, you want them to stay put, and you want the facilities as much as possible to flow around them, because even a trip to a hospital can seriously injure an elderly, frail patient. And although I'm not there yet, I got a knee that doesn't work and a couple of other things. So this presentation outlines a systems engineering perspective to the whole thing, not a healthcare perspective, although I'm modeling healthcare systems. These are the 12 methodologies I use. One of the reasons I look at standard methodologies when I'm analyzing a system is that each one of these methodologies has literally hundreds of companies that have used it. So you're pretty sure that even though you're not using all of it, when you get into the details will work for you. So I don't want to go list each one of these, but this is the viable systems model we're talking about over here. The next slide will be 12 points for collaboration. A key part of this is Michael Porter's integrated practice units value chain. And then the technique I use is an IDEF modeling, which is a hierarchical modeling technique. And then on the implementation side, there's Lean Six Sigma, Carnegie Mellon's People Capability Maturity Model, PMI's Portfolio Program and Project Management Standards. and once again, the reason you do this as you get into more and more detail, you want the methods you're using to work. If you're always inventing new methods, or you think you're having brilliant ideas, my experience with brilliant ideas is, I don't know, 75% of them don't work, at least, and I'm being kind. So at Xerox, I walked into a room and there's a sign on the wall that says there are no bad ideas, and I opened up with 95% of your ideas are gonna be bad. Let's find the 5 good ones that are gonna work. And that's from a systems engineering perspective, not a touchy-feely perspective. This is an explanation of what's going on over here. So at every one of these stages, this is the top level of the organization. Then when you get to develop and manage healthcare services, market and sell, and if you don't think you're marketing and selling in healthcare, think about immunizations, think about public blood pressure checks, think about telling people how they ought to eat so they don't end up in the healthcare system. What you're trying to do is improve the healthcare of the community from your system. This has been changed significantly from the APQC model, but deliver healthcare services is, I'll talk more about the details of this and the rest. And when you think about who the customer is, the customer isn't the patient, the customer is the government, because the customer is paying a bill. So this takes on a whole new dimension when you're talking about how you pay for all of this. So this isn't mentioned in the white paper, but one of the things we've done is relate the 12 points for collaboration to the 12 pillars that the World Economic Federation uses for assessing the business environment in a country. So I don't want to get into this because this does impact it does impact how healthcare organizations would do business, but the primary focus that we're concerned with today is improving healthcare system. One of the things that CSI invented is the collaboration health check, and we use this polar plot to evaluate what the benchmark is for these things, and then what your organization, based on your self-assessment, is at now and where you want it to be in the future. This is, and I always get APQC wrong. I want it to be Association for Process and Quality Control, but it isn't. So I'm not gonna try and remember what it is. It's this is center and this is quality, and I never get the AP right. But at any rate, they have defined a set of processes for different industries. And if I'm modifying this significantly, you ask, well, why do you even use it? What's particularly good is, whoops, I shouldn't touch that, should I?
That's right.
No. Okay. So, I'll keep my hands to myself. What's particularly useful is the explanation of the management and support activities, because most any organization has the same kind of enabling activities. The 4.1 through 5 haven't been changed with regard to their model, but 4.6 has been changed to reflect Porter's integrated practice unit. Porter wrote a book, Changing Healthcare, in 2006, and this has been applied to a whole bunch of different areas. And basically it says, with regard to a patient, want to monitor, diagnose, prepare, intervene, rehab, and manage. And then there are sub-activities to that. So this is kind of what a high-level, a simplistic diagram for a high-level process model looks like. This comes out of Joanne Lynn's Medicaring book, and basically she talks about risk factors, health conditions, goals, and interventions, but what you really begin to see is when she talks about long-term support, it has a significant impact for what Porter calls manage at the end after a healthcare process, because it's much more sophisticated and much more complicated than the average person. Frequently, if you fix, a young person comes in, broken leg, fix it, out the door, little rehab, and there's no management involved. But with a frail elderly person, after you diagnose something, maybe they have 4 things wrong with them, then you've got the problem of drug interactions and a whole bunch of things, which will require a lot of monitoring. Okay, this is the way I think, so I'm not going to explain it, but this is a hierarchical model, and this shows APQC's top level, and then shows deliver health care at the bottom. And then we go to the next slide, and if you don't think that we're thinking about detail, this is Porter's view of an integrated practice unit. But then here are all the computer systems, resource management, all the other things that have to support this when you're actually curing multiple patients. So if you think of this as a portfolio of projects, and each person is a portfolio, where there's a project for lab tests, there's a project for management within the hospital, in a hospital bed, management for how he's processed through the operating theaters, management through rehab, and then these things change based on what you find out. It's a pretty cool resource management problem. I was talking to my IT person about that. He says, well, you'll have to change it second to second. I said, no, probably hour to hour, which is a little more than most resource management people talk about, but it's a pretty cool technical problem anyway. So, and once again, here are the long-term support services, where Porter over here is much more simple. And this is when I do a consulting assignment. I worked this page out for consultants at Xerox, because I was a consultant at Xerox, and I try to tell them how to interview people. And one of the things you want to know is, what are the main activities of your job? What are the key outputs? What are the key inputs? What regulatory functions do you depend on? If you're a doctor and you're diagnosing, you're dependent on lab tests. You're dependent on a whole variety of things. And then how are you going to measure this? How are you going to tell whether you did a decent job? And then there are 5 dimensions of knowledge: culture, content, process, technology, and infrastructure. So you can see we're looking at this from a pretty comprehensive point of view. Usually what happens is you do 20 or 30 interviews with people in very disparate areas and start to assemble what this looks like, recognizing that this is kind of a top level, but it may not be your top level. And then when Porter talks about an integrated practice unit, he talks about that practice unit being focused on a particular care area. Now, the reason I use U.S. News for hospital care is they have developed a evaluation system for hospitals, and all the hospitals in the United States want to be on the top 10. So just so you know, Mayo Clinic actually dropped to second a year ago, and then they popped themselves back up to first. It's got to do with the number of patients you actually process and the kinds of equipment you have to do evaluations. It's based on outcomes. It's based on on the process itself, and then it's based on risk factors, how often you put people at risk. Okay. And here are the major areas of complex care. So when you see an integrated practice unit, then he orients it around one of these things. I don't think I'd do that. I think I would have the overall model and then have it tailored for specific kinds of problems. Notice he doesn't talk about old people in this whole. This is fundamental to the whole thing. So when you think about everything is a portfolio of projects, a patient is a portfolio of projects, changing the organization is a portfolio of projects. And why do we talk about portfolios and projects? Well, if you're doing a toll gate review on a portfolio of projects, you're worried about value. You're constantly asking questions about what's the value of this process? Is it producing, are these projects producing the values and the goals which we want to achieve? A toll gate review for a process is, are you delivering it on time, to spec, at cost? So those are the kinds of things. Now obviously if you've got a project going totally in the toilet, that'll have a significant impact on the portfolio because you're saying this isn't working, you got to do something else. And one of the things something like this does is gives you an opportunity to look at a portfolio of projects and make judgments about it. I don't know if Jeff's going to show you their portfolio program, but when you think about running a hospital, especially if you think about elder care, and you think about all these elders not in the hospital, then you have to have your emergency room, instead of being people moving in and out, you may have a display like this, which is segmented off for seniors as they develop a problem and decide how the transportation and how the healthcare personnel is being funneled to that person. And it probably, in many cases, won't be a doctor, but it may be an EM tech or somebody else. Just so you know, we do have an idea of metrics, and this is a balanced scorecard. The idea of a balanced scorecard was thought up by Kaplan and Norton and published in the Harvard Business Review in 1996. It talks about financial, internal business processes, employee learning and growth, and patient experience, and then associated with each one of those is a variety of a variety of metrics. Medicare in the United States has 922 metrics, which is pretty special. The World Health Organization has 100, and these are the metrics of the World Health Organization. So I'm pretty sure that all of you are being evaluated by the government and one against several metrics about associated with outcome and mortality. But part of the methodology then says, based on this being your current state, and this is where you want to be from the perspective of goals and objectives, what do you have to measure to make sure you're getting there? And then what changes do you may have to make to get there? The other thing is that I see getting left out from time to time is it doesn't, and it happens frequently with computer systems. People put in a hospital spend $100 million putting in a computer system, and they forget that people have to use it. And so, at least some of my discussion with people have been frustration with not understanding the screens or not understanding how to record information. And when you switch from one system to another, it involves a significant amount of training. So, if you want to develop a training plan, the ideal system for doing that is Carnegie Mellon's People Capability Maturity Model, and that tells you how to improve work workforce competencies and how to manage and measure it. This is one of the books over there is called Healing Pathways Analysis, and basically what this guy has done is taken Lean Six Sigma and applied it to healthcare, and he comes up with two pretty cool acronyms. One of them is sickness, and the other one is defects. Defects is pretty standard. Defects, overproduction, or downtime. Defects, overproduction, waiting, not using employees' abilities, transportation, inventory, motion.
All right, can you just, Rob, will you just jiggle the mouse? Thanks.
Okay. What did you do? Oh, okay.
There
we go.
Thank you, Rob.
So this is I've seen that acronym before. This one I really like, sickness. This deals with the patient, and it basically talks about stress and anxiety, inactivity and waiting, coldness and apathy, knowledge gap, neglect, embarrassment, submission to helplessness and statistics. I'm always impressed when somebody can take something fairly complex and make it simple. As you can see, I'm not that good at it. So what you have to remember in this process, as opposed to other service processes, is you're always dealing with a patient, and half the time they're pretty terrified about what's going wrong with them. So part of this process is making sure the patient is comfortable. The other part, though, is making sure that the doctor and the patient are communicating in a way that's useful to both. Then I've talked a lot about a portfolio of projects and what does that look like. Well, this goes back to what a Six Sigma project charter looks like. It has an impact and benefits, problem statement, goal statement, project scope, project plan, risk accelerators, and team selection. And then the details of that are defined. A lot of what I've talked about in terms of defining a process model are the defined part. You saw the metrics for the measurement plan. When you analyze it in a way that allows some analysis is obvious. You can see bottlenecks, you can see others are not. If you're trying to distribute decision making, part of it comes back to how well do you collaborate, how well are your policies and procedures done. At Xerox, they had management by objectives, and the president of the corporation set her goals, and then the vice president set their goals and objectives from that, and then my boss set my goals and objectives from that. So, and in my case, I had to have an implementation plan. I said, with regard to those goals, here's what you can expect me to achieve in the time frame involved. Okay, this is a little more detailed explanation. Well, it's a less detailed explanation, but perhaps clearer. What you're always trying to do at the management level is arbitrate between what you're doing and what you're changing. And if you don't change to meet the market, you're going out of business. But if you change to meet the market and don't have any money to run your business, you're out of business. So the top level guy or the person in charge has to arbitrate essentially debates between what you're doing now and what you're going to do tomorrow. So, and this has to happen at all levels of the organization. If you're distributing the management function to all levels of the organization, then everybody who has a title of manager is somewhat in charge of looking at the external environment, looking at the internal environment, and asking, can we get this done? And in this is where all of the support processes happen. And one of the things you have to do is monitor that. So that's where the audit function happens and the toll gate reviews happen. I just want to touch on this because whenever you read something about quality control, they talk about the Deming cycle. Well, it's really not the Deming cycle, it's the Shewhart cycle. He invented it. And it's called Plan, Do, Schedule, Act. And this was oriented around manufacturing. And I kind of like Boyd's OODA loops from a visual perspective. Colonel John Boyd was a fighter pilot, and he talked about observe, orient, decide, act. If you think about the way the doctor, or especially an emergency room doctor, does a diagnosis, it's much more oriented around the way a fighter pilot has to think than an engineer has to think. Because a fighter pilot, if he can't react faster than his opponent, he'll be either in a parachute or dead. Same thing happens with an emergency doctor. If he can't react faster than what's ever killing the patient that ends up in an emergency room, and the kinds of thinking involved are significant, because he has 7 or 8 years of education, 3 or 4 years of residency, and he has to bring all that to bear, sometimes in minutes, sometimes in seconds, to make sure he keeps this person alive. So it's kind of a fascinating, in point of fact, I hate to say this, but doctors probably think better than engineers. I was talking to an engineer, and she says, "We're going to teach doctors good science," and I said, "I hope not the one I go to." The one thing that surprises me is you don't ever see ISO 15489 anywhere in the medical literature I've read. It may be there, I'm not, but the several thousand pages I've read doesn't include this. By the way, this was invented in Australia, and it says that in order a record to be ISO 9000, ISO 15489 compliant, it has to be authentic, readable, have integrity, and usability. So it has to go through some kind of audit process. We're building up these huge electronic records sort of pell-mell, and who's checking them? Who's who's educating the patient in a way that you can be somewhat sure that these things are consistent across patients? And then we're going to run big data on that, and we're going to produce all this amazing results. I was telling people that 30 years ago. It hadn't happened yet. Okay, just to review here, we talked about having a process framework, and the reason we want this framework is to help us develop a current state fairly quickly. People don't want you thinking 3 or 4 years about how to do something. You usually get 2 months max in order to come up with some sort of reasonable approach, reasonable definition of a current state, where you might want to get to, and where you could get to reasonably within a year, and your return on investment has to be usually a year or a year and a half, otherwise it doesn't happen. This is turning out to be key. One of the things Michael Porter didn't do is he invented his own approach to what Six Sigma does. Six Sigma is pretty comprehensive. Dean's book over there is only 200 pages, but if you want the book on Six Sigma, it's his deck, 1,200 pages. It's full of marginally comprehensive statistics. Once again, we're modifying all of this at the lower levels to accommodate senior care, and senior care has an impact on diagnosis, some interventions if they involve drugs, because us old people can have 3 or 4 things wrong with us, and then if you give us 3 or 4 kinds of drugs, we don't know whether they're going to interact or not. And then home care, or the managed part of the integrated process unit process, is significantly changed. And then Jeff can talk to this better than I can, but I had this image of an emergency room being a screen like this, where you had potentially multiple seniors and then multiple project plans associated with those seniors, so you could bring those up whenever you encountered a patient who was in some kind of distress. So with that, I think, questions?
I might start. I have a question. So first of all, a lot of this content is in a white paper that we've got available to you, which you can take with you when you leave. And the one thing that's addressed in the white paper is why are we doing all this? So what does it do in terms of cost or quality or speed, acceleration. Why are we doing it?
Yeah, if you don't get 30% cost savings, you're probably not gonna do it. And when I look at this problem versus other problems, versus other organizations, 30% ought to be fairly easy. Partly because, you have problems like census in a hospital, number of people, empty beds. With seniors, it's even easier because if they don't end up in the hospital, that's a huge savings. So when we looked at this, the United States has something called PACE. The CA, Care for the Elderly, I seem to forget the first two, program, something Care for the Elderly. And they're looking at $3,000 a month for care in the home versus $10,000 a month for care in a home, an old folks home, and it's even worse if they end up in the hospital unnecessarily. So 30% is pretty easy when you're looking at those numbers. You can afford a fair amount of support at home if you can avoid having them end up in the emergency room in a hospital, or worse, some extended care in the hospital and then over to a nursing facility. So the other problem the United States has anyway is that people under 15 years old are projected to increase 17% by 2050, and people over 85 are projected to increase 231%. So the pressure on the healthcare system is going to be pretty spectacular if we don't figure how to do this effectively. The other key, one of the things I didn't mention, is this sales and marketing thing. You really get into the quality of life, like when you're old with a severely disabling something. Do you want to spend 2 years in a hospital or 8 months at home doing what you feel like, watching football, drinking beer, whatever? So people have to, part of this is counseling and coming to grips with the fact that you're gonna die. The chances of me dying are much higher than anybody in this room, simply because of my age. But how do you want to live the rest of your life? And people are very uncomfortable with that. So part of the sales process associated with elder care is getting people to deal with the quality of life. And I just wrote a book that has nothing to do with healthcare, but it has everything to do with value. So getting people to see, also getting medical people to see how you treat a senior person with regard, based on age, and how you treat a young person. If I'm a young person and I come in with a tumor, you cut it out, you rehab me, and I'm out the door. If I'm an old person and I come in with a tumor, you got to ask yourself, is cutting it out going to kill him, because all the systems are weaker? So I think doctors are more focused on short-term fixes rather than a long-term extended quality of life for a particular individual. So those are part of the things that have to get inserted into the equation and aren't.
Thank you. Any other questions? Because I actually think that's an interesting segue into our next speaker, who's going to actually talk to us about quality. So given we started a little late, I think we might end there. Dr. Jones will be around today if anyone wants to speak to him after this, but I think we should stand up stretch for a moment and walk back to the collaboration hub.